Thank you, Professor Sagon Mongkhunsuk, the Dean of the Faculty of Science, Mahidol University, for the welcoming remark. May I now have an honor of inviting Dr. Uwe Morawetz, the Chairman of International Peace Foundation, to deliver a statement regarding the bridges, dialogues towards a culture of peace.
Your Excellency, Privy Councillor, Professor Kasem Watanachai, ladies and gentlemen, friends, Sawadee Kap and welcome to the third ASEAN event series, Bridges, Dialogues Towards a Culture of Peace. Bridges is facilitated by the International Peace Foundation under the patronage of 21 Nobel Peace Laureates based in Vienna. The events are hosted in cooperation with various local partners and institutions, including some of the country's major universities. Since November last year, Bridges has been continuously held in Thailand, Cambodia, and the Philippines, involving the participation of Nobel laureates and other eminent keynote speakers. The third ASEAN series of Bridges is an independent contribution to the Decade for a Culture of Peace and Nonviolence, which was initiated by the United Nations General Assembly. It follows the series of 350 Bridges events, which the International Peace Foundation has already hosted in Thailand, the Philippines, and Malaysia since 2003. The pluralistic program of Bridges highlights the International Peace Foundation's intercultural and transdisciplinary approach towards peace. The foundation does not take sides, but acts as a mediator by creating an independent platform for dialogue where representatives of science, politics, economy, culture, religion, the media, and youth can meet, share their viewpoints, listen to each other, and find mutual ways of understanding and cooperation. Therefore, the foundation itself is a bridge and a facilitator between different language groups in our divided societies, where politicians speak another language than scientists, and business and religious leaders another one than artists. In a highly interdependent world, problems cannot be solved by either one of these language groups only, but by working together. After the success of Bridges in Thailand, the Philippines, and Malaysia, the International Peace Foundation has now been invited by other ASEAN countries to build further bridges towards peace and international understanding by expanding its program in Southeast Asia to stimulate the intellectual, scientific, and cultural exchange in the region. The aim of Bridges is to facilitate and strengthen dialogue and communication between societies in Southeast Asia with their multiple cultures and faiths, as well as with peoples in other parts in the world, to promote understanding and trust. The events aim at building bridges with local universities and other institutions in Southeast Asia to establish long-term relationships with Nobel laureates in all fields, which result in common research programs and other forms of long-term collaboration. By enhancing science, technology, and education as a basis for peace and development, the events may lead to a better cooperation for the advancement of peace, freedom, and security in the region with the active involvement of the young generation, ASEAN's key to the future. This is why Bridges is not designed as a one-time event, but as a continuing process of synergies to make the series of events a sustainable success for Thailand, for Cambodia and the Philippines, and for Southeast Asia as a whole. I am grateful to the Faculty of Science at Mahidol University and its Dean, Professor Sagon Mongkhunsuk, as well as to our other partners and sponsors who have enabled us to make the idea of Bridges a reality. I would like to say thank you to everyone present today for taking part in this program. May it help us to facilitate a new culture of peace through dialogue, transcending its definition as merely the absence of war or armed conflict, into a new understanding what the basis for peace is: education. In this sense, we welcome today the 2008 Nobel Laureate for Medicine, Professor Francoise Barre-Sinoussi, who has agreed to come to Thailand to support the events. We all look forward to her keynote speech and to her important contribution to build bridges. ขอบคุณครับ
Thank you, Dr. Uwe Morawetz, the chairman of the International Peace Foundation. May I now have an honor of inviting His Excellency Professor Dr. Kasem Wattanachai, the Privy Councillor, to deliver an opening speech and to present a flower bouquet to express an appreciation to the keynote speaker, Professor Francoise Barre-Sinoussi, for her invaluable time and her visit to Mahidol University Faculty of Science. Your Excellency, please.
Professor Francoise Barre-Sinoussi, Professor Ponchai Matangkasumbat, the former president of Mahidol University, Professor Skon Mongkonsuk, Dean of Faculty of Science, Dr. Uwe Morawetz, Chairman of the International Peace Foundation, distinguished guests, ladies and gentlemen, it is truly my pleasure and honor to be here and have the opportunity to make an opening remark on occasion of the Bridges Dialogues Toward a Culture of Peace event series that the International Peace Foundation co-organizes with Faculty of Science, Mahidol University today. Through the lecture series of Bridges Dialogues event, today we have a remarkable opportunity to welcome our guest of honor, Professor Francoise Barre-Sinoussi, the Director of the Regulation of Retroviral Infection Unit at the Pasteur Institute in Paris. Professor Barre-Sinoussi was awarded the Nobel Prize for Medicine in 2008, together with Professor Luc Montagnier, for their discovery of the human immunodeficiency virus or HIV. This discovery made rapid cloning of the HIV-1 genome possible, and most importantly, it led to the development of methods to diagnose infected patients and to screen blood products, which has limited the spread of the AIDS pandemic. Today, Professor Francoise Barre-Sinoussi will deliver a special lecture on the topic of future challenges in HIV/AIDS prevention and therapy. The combination of prevention and treatment has substantially decreased the spread of the disease and dramatically increased the life expectancy among millions of treated patients worldwide. As we are all well aware, today's world is unfortunately filled with so many conflicts. Many parts of the globe has battles between ethnic groups, faiths, and other differences, while fights against hunger, disease, and deterioration of global environment are still far from over. Therefore, today's topic is genuinely relevant and timely, helping us to understand how science could play a crucial role in promoting peace and understanding for mankind. May I take this opportunity to express my sincere thanks to the Faculty of Science, Mahidol University, and the International Peace Foundation for co-hosting this event, and wish you all the best for fruitful and enlightening presentations. At this point, I now declare to open this special event series of Bridges Dialogue of Culture for Peace with the special lecture in the topic of future challenges in HIV and AIDS prevention and therapy by Professor Francoise Barre-Sinoussi. Thanks for your attention.
Thank you, Your Excellency. May I now have an honor of inviting His Excellency to present a flower bouquet to express an appreciation to the keynote speaker. And may I now have a privilege to invite His Excellency Professor Dr. Kasem Wattanachai, Professor Francoise Barre-Sinoussi, Professor Sakon Mongkonsuk, executives of Mahidol University to join in a photo session, please. Thank you, His Excellency and Excellencies. May I now have an honor of introducing the keynote speaker of this afternoon lecture. Professor Francoise Barre-Sinoussi received her PhD in virology from the Pasteur Institute and the University of Sciences in Paris in 1975. After a brief internship at the National Institute of Health in Bethesda, Maryland, she returned to the Pasteur Institute, where she is currently the director of the Regulation of Retroviral Infections Unit at the Pasteur Institute in Paris. As for her research work, Professor Barre-Sinoussi has been involved in retrovirology research since the early 1970s. She is recognized for her contributions to HIV/AIDS research, in particular as the first author of the publication in 1983, reporting the discovery of a retrovirus, which was later named human immunodeficiency virus, or HIV. In 2008, Professor Barre-Sinoussi was awarded the Nobel Prize for Medicine in 2008, together with Professor Luc Montagnier, for their discovery of the human immunodeficiency virus, or HIV. So, ladies and gentlemen, please welcome Professor Francoise Barre-Sinoussi.
To the Faculty of Science and Mahidol University for hosting this conference today, and I would like also to express all my thanks to Uwe Morawetz for inviting me to come here in Thailand for this Bridges event. What I would like to do this afternoon is certainly to speak about the future challenge in HIV/AIDS prevention and therapy, but before maybe start by some of the history, because I think that history is important, in particular for the new students, the new generation of the future. They have to keep in mind the history for the future. Indeed, it was mentioned that I started myself my studies in universities in the at the end of the 60s. At that time, I must say that we were thinking that at the end of the middle of the 20th century will be the end of infectious disease. So my own interest at that time and curiosity and motivation was certainly not for infectious disease itself, but mostly for other human pathology. And at that time, at the end of the 60s, very early 70s, we were very interested in cancer and leukemia. So is why I started really myself to work on retroviruses as a potential cause of cancer and leukemia. When I started, indeed, that was the years of the discovery of the reverse transcriptase, the enzyme that is used by retroviruses to divide into target cells, which was also honored by a Nobel Prize. So I was working on interaction between retroviruses, mostly animal retroviruses, and the host, to see what role these retroviruses could play in leukemia and cancer, when we got this first alarming sign of an emerging epidemic published in MMWR, the CDC journal, in June 1981, reporting the first cases of pneumocystis carinii associated with profound immune depression in very young homosexual patients in the United States. Soon after, the first cases were recognized in other patients. Hemophiliac, also women presenting with the same symptoms, and as well as first cases of infected children born from infected mothers. If I mention that, it's because as soon as 1982, we had already the knowledge of the mode of transmission of the etiological agents. We knew that the etiological agent could be transmitted by sexual route, by blood, and from mother to child. And this is really, if I'm showing you this slide, is to keep you in mind, especially the future scientists in the room, that scientists alone should be careful about the observation of clinicians and epidemiologists as well. Because for our case, working in biomedical science, it's really the clinicians that came to us at the Pasteur Institute because they were starting to see the first case of this disease that later was called AIDS. And they asked us a very simple question. You, as a retrovirologist, do you think that a retrovirus could be the cause of this new emerging disease? Of course, if they came to us, it's because soon before, in 1981, the first human retrovirus was identified in the United States and very soon after in Japan. We knew it as human T leukemia virus. And the clinician knew that this human retrovirus was capable to infect T cells. And they said, look, in our patients, they are losing all their T cells. We say, yes, okay, but HTLV, it's a retrovirus that immortalizes the cells. The cells are proliferating, they don't die. However, we had in mind that another retrovirus in animal, feline leukemia virus, was capable to cause in cats immune deficiency, and very often the cats were dying of immune deficiency before dying of leukemia. So we told our colleagues, the clinicians that are on this slide, look, we have today the new technology, and we have the technology in the lab, especially since it was reported the identification of growth factor, at that time called T-cell growth factor, now known under the name of interleukin-2. So we had the possibility to grow T-cell into culture. Now we have to decide the approach that we are going to use. The reason why on the slide I say, when you start a research program, don't keep in mind dogma. Because if we had started with the idea that HTLV could be the cause of this emerging disease, indeed, we certainly did not have done what we did. We would have wait for weeks into culture to see the expansion of transformed cells. We said, no, we're not going to do that. We're going to look every 2 or 3 days maximum to see whether we are capable to detect any viral activity in the supernatants of the cells, reverse transcriptase activity, namely. The second important decision that we took together with our colleagues, the clinicians, we said, look, you want us to try to identify a virus from CD4 lymphocyte in patients that do not have any more CD4 lymphocytes in their blood. This is certainly not the best moment. So our colleague, Willy Rosenbaum, on this slide said, okay, but before they are developing generalized lymphadenopathy, and we asked, can we have a biopsy, a lymph node biopsy from a patient? And the three partners in this story appear, the patients. The patient, because very kindly, one patient accepted only for research purpose to have a lymph node biopsy. So it's how the story began, and it's how it's really a very nice cooperation that was successful between clinician, health worker, patients all together. It's how we report in the May 20, 1983, for the first time, the identification of a virus that at that time we call lymphadenopathy-associated virus, because it was isolated from a patient with lymphadenopathy. We did not call it at that time yet HIV. We report in that paper that the virus could be propagated on peripheral mononuclear cells of blood donors or on cord blood cells. We report that we were able to detect a reverse transcriptase activity which was associated to virus particle of the same size and same, let's say, morphology of retroviruses, but according to HTLV1 condition. However, the morphology of the particle was not already the one of HTLV1. Indeed, we are in contact with our colleague Bob Gallo in the United States. We asked whether we could have reagents, HTLV1 reagents. And in that paper, we were able to show that one of the proteins of our virus, LAV, was not cross-reacting at all with the equivalent protein of HTLV1, the P24. It was the same for another protein of HTLV1. We were reporting also in that first paper that a second patient was presenting antibody against our virus, and the other donors or other patients with other disease were not reacting against our virus. So that was really the beginning of a long story. We certainly did not at that time, in 1983, at the reality of the magnitude of the epidemic that we have today. We realized only later on that we had to face a terrible epidemic affecting the whole world. After this report, we had to convince the scientific community and the authorities that this virus, LAV, was the cause of AIDS. That means that in our lab, we had to stop any other research program that was going on. We had also to mobilize other cooperation against cooperation, multidisciplinary cooperation. That was a key issue and is still a key issue for the future. We had to mobilize other like immunologists, molecular biologists, and so on, to come and work with us, to make the link between this virus and the disease itself, to show that we were able to isolate the virus only from patients with AIDS or AIDS-related symptoms, but not from any other disease. Together with clinical virologists, Christine Ouziou and Francoise Barre-Sinoussi, we set up very rapidly ELISA test for making seroepidemiological investigation to show that only patients with the disease were presenting antibody against our virus and not the others. We had to characterize the virus itself as genetic level, antigenic level, and so on. So, as you can imagine, it was quite a lot of work to do, but we knew already that we had to rush. We had to rush because we knew that the virus was transmitted by blood. We knew that we had to develop very rapidly, as it was mentioned before, serological tests for the diagnosis and to avoid at least transmission by blood. That means that we had to mobilize also the private sector. Cooperation again between the public and the private sector, and we had a very strong and efficient partnership with the company Sanofi Diagnosis Pasteur. So if I mention very rapidly these stories, because HIV research is really an example of a wonderful collaboration at multidisciplinary level, and it's an example of translational research, very rapidly translational research. After the identification of the virus, we made the diagnostic test to prevent the transmission by blood, as I mentioned. But even by making study on the tropism of the virus for CD4 cells, and also to study the cytopathic effect of the virus on these cells, we brought the evidence that monitoring CD4 cells in patients was the right way to go. We characterize the HIV-1 replication cycle very rapidly with Dominique Dormois and other colleagues working with us, and the reverse transcriptase of this virus, and we started as soon as 1984 to test for antiretroviral drug on the purified reverse transcriptase activity of this virus. It turned out that the first drug we tried was not the good one. But not so far after, in 1985, 1986, colleagues in United States showed that AZT was a very active anti-reverse transcriptase drug and was very fast tested in human as the first antiretroviral drug, and it was the first antiretroviral drug showing a prevention of mother-to-child transmission. Sorry. So, during the last 27 years, I'm showing this slide to indicate only very important, the main milestone that has been made all over the year. It was mentioned before, we characterized very rapidly the genome of HIV-1, and as soon as at the end of 84, we knew already by comparing the virus from one patient to the virus of another patient that they were not the same. So we very rapidly learned that we had to face a very diverse virus. And over the year, we have learned about the diversity of HIV-1 at the Pasteur Institute. We also isolate the second type of virus, HIV-2. And you know that today, we know that both virus HIV-1 and HIV-2 result from introduction into human of monkey viruses, chimpanzee for HIV-1, Suti Mangabe for HIV-2. So we have learned a lot about HIV biology, HIV pathogenesis all over the year. I am not going to enter into detail. If I'm showing you this slide, it's just to indicate that fast because of this very strong interaction between us, because also we were at that time a small community of people involved in HIV/AIDS all over the world, and it was a lot of solidarity to work really strongly, efficiently together. As a result, therapy was developed. And in 1996, 1996, we had the first data showing that heart, the combination of 3 antiretroviral drugs, was very efficient to treat the patient. Indeed, today, just a word on this slide. We have been very efficient in diagnosis, very efficient in therapy, not so efficient, we must confess, in prevention and in vaccine development. I will come back on that point later. Regarding therapy, today we know clearly that antiretroviral treatment, the highly active antiretroviral treatment called ART, that associates 3 drugs together, is reducing the mortality of more than 85% in patients that are treated by this combination. Today we have 6 classes of molecules. These are molecules that inhibit the reverse transcriptase activities. We have 2 classes, nucleoside inhibitor and non-nucleoside inhibitor. We have protease inhibitor, one other enzyme of the virus, fusion inhibitor, the inhibitors that inhibit the fusion between the viral membrane and the cellular membrane, integrase inhibitor, very efficient drug. And lastly, we have a drug that can block the recognition of the virus by the virus of a co-receptor of the virus on the cell surface, the CCR5 receptor. We have overall a panel of about 30 drugs for heart today. This is really a wonderful issue. Today we can say that in the rich country, in Europe, United States, we are not speaking anymore about AIDS. We are speaking about people living with HIV on heart. This is wonderful for the rich country. But the story also shows how much inequities we have in health. Indeed, after the disease was recognized in the States, the virus in France, I was lucky enough, I say lucky enough, because that really changed the course of my scientific career, I think, to replace Professor Montagnier for a WHO meeting in Central African Republic in Bangui. That was in 1985. For the definition of AIDS in Africa based on only clinical criteria. Indeed, I discovered the situation in this very poor country of Africa, and it's how I decided to start to be involved again together with others. Together with others to start training and to improve education about viral infection, about those diseases, and the first course was in Central Africa in 1987. We followed by courses in Vietnam in 1988. In 1988 in Hanoi, before the first case of infection was recognized in Vietnam. Indeed, it was recognized 3 years after, in 1991. So that was a start for training, strengthening capacity, improving human resources also in those countries since the very early years of HIV. And that reminds me, as a scientist working at the Pasteur Institute, what Louis Pasteur had already in mind himself. He had the vision. He had really the vision that we should still have today, saying that science has no barrier, no frontier, because knowledge is belonging to humanity and is really the flame that enlightens the world. I think we should keep in mind the Pasteur vision, even today. When we made progress in science, We have success in science, but very often it's much more complicated to translate the progress in science into large-scale public health action. There are several steps and issues that should be considered. Very often we have to validate the scientific progress and the scientific evidence in the site, locally, to have credibility for the leaders that will make the decision. We had to set up also on-site surveillance epidemiological study. We had to establish well-characterized cohort directly on-site. We had to make operational and clinical research directly on the site, as well as socio-economical research to provide scientific evidence for the policy makers. So we have a need for a strong interface between scientists, health workers, and the policy makers, the providers of drugs or the provider of kits. We have to make very strong interaction with the patients, with the civil society themselves, if we want to be successful. We had to participate to awareness, diffusion, advocacy, in order to be part and give advice for national program guidelines and decisions, and to help for coordination of activities directly on site. Research, for me, should be a permanent component of all the activities. Indeed, if you look carefully in the countries that are doing quite well in HIV/AIDS, like yours in Thailand, indeed, all the components were there. Research started in the country, directly on the country, and you have today very good operational and clinical research, let's say, here in Thailand. And you have action, intervention for prevention, intervention for access to care and treatment for the patient, and monitoring of the patient. This has been possible here in Thailand, like in any other country, because of strengthening local infrastructure, making capacity building, training of health workers, improving the organization of the health system. Even in my country, in France, it was like that at the beginning. We had also to improve our health system. So we had three really compulsory synergy components. It's the synergy, which is also a key issue in that story, as it is for most of the things that are important for human beings. And we have examples. We have examples of successes and failure in different countries. Of course, I'm showing Thailand with the early success of Thailand in terms of prevention because of the national program, showing very rapidly that at the end of 2008, the prevalence of infection strongly decreased in Thailand because of the decisions that were taken. We had other countries like Uganda that was quite successful as well in terms of education, prevention programs and counseling programs. And you have the case of KwaZulu-Natal in South Africa, where you can see that all over the year it has been an increase of the prevalence of infection up to almost 40% of the population there. The differences in the three countries here was political willingness, really. Another example in the region, the one I know quite well, is the example of Cambodia. Cambodia, it was really a mobilization and a response of the national authorities in Cambodia with support of international organization, institution, we started as soon as we could after a training program, several of us to set up research directly in the country, in Cambodia, in order to provide information. We had evidence through further MSF program, Médecins Sans Frontières program in Cambodia, that the treatment could be very efficient in Cambodian patients with more than 90% effectiveness. And as a result, today, I must say that first of all, without any intervention, we will have seen the curve growing up in Cambodia, and the reality is today that we have less than 0.2% of prevalence of infection in Cambodia. And I can say that today, about 35,000 patients are on heart in Cambodia, the number of patients that need to be treated, based on 200 CD4 cells. This is also another example that showing that antiretroviral treatment is, the coverage by antiretroviral treatment is starting to show consequences on mortality in some countries in Southern Africa. You can see here that with antiretroviral treatment, there is an increase of the rate of decrease of mortality compared to the absence of antiretroviral treatment. Today, the progress in access to antiretroviral treatment in low-income countries is significant. It's significant because of the international efforts through the Global Fund, through the Clinton Foundation, through the Bush program, and so on. You can see on this slide that we have multiplied by 10 the number of patients that are on heart in low-income countries between 2003 and the end of 2008. It's wonderful. Today we can say that about 40% that need to be treated by ARV are on ARV. Is not sufficient. Is not sufficient because you can see on the bottom of the slide that for every 2 new persons that start heart, there is 5 new cases of infection. So that means that we still have to continue our effort and to do better. To do better for the future, especially because we know today through the WHO recommendation based on scientific evidence again that starting heart at 200 CD4 cells is not enough. We should start at 350. That means that we need more effort than ever. The reason why we as scientists are there to provide evidence, as I said, to convince government leaders and health authorities to take the decision for the benefit of the public health. And it's our role, it's our responsibility, of course, to provide the scientific evidence, but also to make pressure on the government leader and health authority, to make pressure with others, with our colleagues, the activists, and we know, and HIV/AIDS has been, I think, one of the best examples, how much representative of patients can make, to make pressure with others, with our colleagues, the activists, and we know, and HIV/AIDS has been, I think, one of the best examples, how much representative of patients can make the pressure on the government, can make the pressure on the private sector to reduce the price of the drug and to allow also the production of generic. So we have again to work all together to improve the health of others. We have in parallel to continue science. Because even today, 27 years after the discovery of HIV, still, you have seen, prevention, treatment are the priority. And we have new priorities also as well to treat. We have to consider co-infection by HIV and tuberculosis, co-infection of HIV and hepatitis B or hepatitis C, and so on. We know that in some country, particular low-income country, when you treat patients and they have both TB, for example, and HIV, they are doing better for HIV infection, but they develop immune reconstitution syndrome. And some of them die of immune reconstitution syndrome. So that means that we have to improve our knowledge of co-infection and treatment of co-infection. We have to work, and I will say a word in a moment, on complication and long-term heart in patients. We have to work in order to have new therapeutic strategy and new vaccine strategy for tomorrow. And this will be based on a better knowledge on the establishment and persistence of HIV reservoir in the different compartments of the body. We also have to understand the very early mechanism during the acute phase of infection. I'm speaking about the first hours after exposure to the virus, the first 96 hours after infection. We know today that everything is decided very early, even if it is a slowly progressing disease. And we are far to know everything. We are far to understand the very early signals that are responsible for abnormal immune activation that is seen in HIV-infected individuals. We are far to understand the signal that the virus or components of the virus are able to abrogate or to alter the crosstalk between cells of innate immunity and cells of adaptive immunity. We have to understand better the mechanism of protection for which that a vaccine should induce. We don't know. We should be frank, we don't know which kind of response a vaccine should induce to be effective. We had to understand better, we did already a lot, but we had to understand better the interaction between viral factor and cellular partners at the level of the cells in order to develop new molecules to stop those interactions. After more than 2 decades, there is still gaps in HIV treatment and gaps also in equity. Indeed, we have today, let's say, more or less 2 profiles. We still have AIDS-associated morbidity in resource-limited setting because we still need to get the drug to all people that need it. We had another profile, which is a profile of rich or middle-income countries that is appearing. The non-AIDS-associated morbidity related, which is caused by high complications like resistance to drug, metabolic disorders, including cardiovascular injury, premature aging, cancer, that we are starting to see in a significant proportion on patients that are on long-term heart. We have to understand better the impact of the treatment toxicity together with the role of HIV itself in inducing a persistent inflammation that remains even on heart. We know that we don't have a full reconstitution of immune cell function. And we have to consider the lifestyle also in those complications. And lastly, of course, we are all dreaming about the eradication of HIV. I prefer to say, let's dream about a functional cure for HIV. We are not yet there, but there is a renewed effort that began already for at least reducing the size of the reservoir in different compartments of the body. So there is need still today for more mobilization and more research to develop new molecules and to make these molecules available for all. And we need to find solutions to have a functional cure of this infection. There are potential strategies that are already ongoing for tests. The idea is, for example, to intensify antiretroviral treatment very early after infection in order to reduce the size of the reservoir. There is several clinical trials ongoing in the world on that aspect. The very early intense antiretroviral treatment was tried. The first clinical trial, to tell you the truth, were not so promising. We have tried already also to enhance anti-HIV immunity by using immunomodulating agents or even by vaccine therapy without any success up to now. That does not mean that we should stop, because like for vaccine, I think probably we did not try the best strategy, and we have to learn more about immune pathogenic process. We have new drug with improved penetration and patency that will be tested, as well as a new strategy to try to unlock the latency into HIV-infected cells. So it's ongoing, and we should remain optimistic for the future. What about prevention? Prevention, antiretroviral treatment today should be part of the prevention strategy as well. ARV might be used in pre-exposure prophylaxis or in post-exposure prophylaxis. There is several studies going on already in different countries in the world, clinical study to evaluate pre-exposure prophylaxis and post-exposure prophylaxis. The test and treat concept is also ongoing for trying to show that we should validate first this concept before application. However, we know already that antiretroviral treatment reduces the viral load in the level of the genital secretion, and it has been reported at a conference in February in San Francisco that when a partner is infected by HIV and on treatment, you have a reduction of more than 90% of the risk to infect the non-infected partner. So this is a very nice data in favor of the test and treat concept. Up to now, another means of prevention, microbicide, have not been successful at all. The non-specific microbicide like benzalkonium chloride, for example, those approach, non-specific approach, cannot work because they are too toxic. They create lesion, and even they increase sometimes the transmission of the virus. But we have today a new kind of approach, which I found personally very interesting, to use new specific microbicide. But in the microbicide, indeed, what do you have? Antiretroviral drug. And I think this is really an interesting approach. Again, study are ongoing. Circumcision. Circumcision, of course, circumcision not alone. Not alone, because we know that it can only reduce the transmission of between 50 and 60%. That's not enough alone. but associated to others, it might be something to consider. Vaccine, I will come on that point. Up to now, until the Thai RV144 trial, it was a total failure of the classical approach, we must say. This is just to show you that the test and treat concept, we stop viral replication by ARV, we have undetectable viral load in blood, and very often in high frequency in genital secretion. It was a model published at the end in the Lancet at the end of 2008, showing that if we apply this concept of universal voluntary HIV testing and immediate treatment in 2020, we will stop the HIV epidemic. Of course, it's a dream, because we all hope that we will arrive to this situation, but we know that it will not be so easy. So reducing the incidence of HIV-1 is today one of the major priorities in global response to HIV. And we have to combine for this priority of prevention all the different approaches: education, information, counseling, for improving behavioral changing, usage of condoms. We have to consider treatment. We have to consider biomedical strategy like circumcision and maybe others like specific microbicid in the future. But we have one component here that we have to keep in mind, which is today one of the major obstacles for the testing of HIV individual. We have today too much stigmatization, discrimination against HIV infected individual, and as a consequence, people don't go for the test. And this is really one key issue if we want to improve the proportion of patients that go for the test and will benefit earlier of the treatment in the future. HIV vaccine history, few words. It started in 1987 already with the first phase 1 trial. Very empiric approach since between 87 and 2007, more than 110 trials with about 67 products used as vaccine candidate in almost 30,000 human volunteers. What we could say at the beginning in the phase 1 to trial is that vaccines were usually safe, and some of them were showing some immunogenicity, and we had to wait 2003 to have the first data of the first phase 3 efficacy trial by a vaccine candidate of vaccine, which was corresponding to the envelope of the virus, but the monomeric form of the envelope. And this trial clearly show a lack of efficacy of the recombinant, monomeric recombinant GP120. We had to wait 2007 to have the data of the second efficacy trial, called the STEP trial and the PAMBILI phase 2B trial, using as a candidate adenovirus type 5, all the different approach. Education, information, counseling for improving behavioral changing, usage of condoms. We have to consider treatment. We have to consider biomedical strategy like circumcision and maybe others like specific microbicid in the future. But we have one component here that we have to keep in mind, which is today one of the major obstacles for for the testing of HIV individual. We have today too much stigmatization, discrimination against HIV infected individual, and as a consequence, people don't go for the test. And this is really one key issue if we want to improve the proportion of patients that go for the test and will benefit earlier of the treatment in the future. HIV vaccine history, few words. It started in 1987 already with the first phase 1 trial. Very empiric approach since between 87 and 2007, more than 110 trials with about 67 products used as vaccine candidate in almost 30,000 human volunteers. What we could say at the beginning in the phase 1 to trial is that the vaccine were usually safe, and some of them were showing some immunogenicity, and we had to wait 2003 to have the first data of the first phase 3 efficacy trial by a vaccine candidate of vaccine, which was corresponding to the envelope of the virus, but the monomeric form of the envelope. And this trial clearly show a lack of efficacy of the recombinant, monomeric recombinant GP120. We had to wait 2007 to have the data of the second efficacy trial called the STEP trial and the Pambili phase 2B trial, using as a candidate adenovirus type 5, including the GAG gene, POL gene, and NEF gene of HIV-1. Indeed, as you probably heard, this trial was stopped. Was stopped not only because there was a lack of efficacy, because of some of the volunteers showed that were vaccinated, we showed even an increased level of infection. And we had to wait September, October 2009 to heard about the study that was performed here in Thailand, the RV144 trials in collaboration with colleagues in the United States, using what we call the prime boost approach, coming to prime the immune response with the first vaccine, with the first immunogen, and the immunogen used was Cambodia pox, containing the GAG, POL, and NF gene of HIV-1, and coming after with a boost with, as a candidate, the recombinant GP120 of HIV-1, both type of HIV-1, the subtype B and the recombinant form that is circulating here in the region in Thailand. The results, you know it, very modest effect, only 30% of efficacy. And we have still ongoing trial today. But what the Thai trial tells us? It has been done on 60,000, more than 60,000 volunteers here. You can see my first reaction when they ask me, what do you think about the results of the Thai results? I say, my God, this is wonderful. The classical education information program is working perfectly well. Only 125 infections out of 16,000 volunteers. That means when you educate, you make good counseling, the preventive methods are used, are really working. In this trial, 74 controls were infected, 51 of the vaccinee were infected, so that means, as I said, 30% of protection. So everybody was excited because it was the first time that at least we showed some efficacy. But we know that 30% of efficacy is not sufficient, that we need at least 50% of efficacy. But at least we have new questions that we can ask based on this vaccine trial, new scientific question. Maybe the strategy that was used, the prime boost strategy, is a good one. we don't have the good immunogen, but maybe we have the good strategy, and we have to work on that, and already I know that people are thinking of doing it. We also might learn from the vaccinee about those that were the lucky ones that were protected, which mechanism of protection they have developed after vaccination. And this is a key issue because we don't know. And we might have to revise even our endpoint for evaluation of vaccine, because in the group of vaccinees that were not, unfortunately, protected, indeed, when you compare to the control group, we found out that the level of the viral load in both groups was the same. So for efficacy, usually we measure the viral load. Maybe not the right things to do. So we certainly will learn from those vaccinees and from other vaccine trials that are ongoing to develop the new strategy of tomorrow. We will certainly learn also from other models of protection in addition to the protected vaccinees. We have those people that are exposed but not infected. It was the case, you probably heard about those prostitutes in Nairobi that were naturally controlling their infection without any protection. We had the model of protection, and this interesting model, what we call the elite controllers. They are not protected against HIV infection, but they are infected. They are HIV-1 positive, but they do not develop AIDS. They never receive any antiretroviral treatment. They have been infected, for some of them, since more than 15 years. They represent a very small proportion of HIV-infected individuals, only less than 0.3% of HIV individuals. But they perfectly control well the replication of the virus. They have undetectable viral load. And of course, one of our dreams is for vaccine to transform HIV positive individuals in elite controller. We have another model which is quite complementary, I must say, because the mechanism of protection against not HIV infection, against the development of AIDS, is totally different. It's a monkey in Africa from which HIV originates. Indeed, those monkeys are natural hosts in natura of a virus very close from HIV, SIV. But in Africa, those monkeys do not develop AIDS. The virus replicates. They are not elite controller at all. You can detect viral load. You can detect virus replication in the monkey in their blood. But the difference is